welcoming everybody. It's really nice to see so many people, all our colleagues and friends. It's very nice to be here again at another of the Hta inaugural lectures. Eva's just been telling me that this is the 19th in a long series. And I think I seem to have presided over almost all of them. And I think I worked out this is my 18th, but we shall see. What this is about is a chance for Professor Eva Kaltenthaler, to give us a lecture, to tell us about the research that she's been doing over a period which spans 20 years, I think, since you came to Hta, pretty much straight up from doing your PhD down the School of Hygiene. And what we do is we'll ask Eva, as usual in these Hta lectures, to talk for about 40 minutes. And then we won't have questions. This is a tradition in our Hta lectures. We don't have questions. What we do instead is we have a boozer outside. And so there will be drinks and nibbles outside. And if there's something that you'd like to ask Eva about or talk to her about, then you can accost her there. If her minders will let you get to her. So I don't think I'd say anything more. Eva, over to you.
Thank you. Can you hear me with this? Can everybody hear me all right? I think I'm on.
Press the little mute button on top.
I did. Yes. I think that's it. Yes? Can you hear me in the back?
Yeah.
Okay. Good afternoon. It's really, really lovely to see so many people here today. I just want to start by saying I always think of my research career as a journey, which is why I've chosen the title. And it's been full of fits and starts and detours and unexpected situations and some real challenges. And I think this is illustrated really well by this photograph. This is me in the Peruvian rainforest in the canopy on a rope bridge 300 feet above the ground, which I did find a little bit challenging. So I think this illustrates a little bit how I feel about my research career sometimes. I've also included the acronym NICE, which it stands for the National Institute of Health and Care Excellence, for those of you who don't know. I've never thought it's a very relevant, appropriate acronym, though, because sometimes the work's not really very nice. Anyway, you'll probably be pleased to know I'm not going to give a lot of detail about my research. I'm going to just touch on some highlights over the years, and I'm actually going to start before I started working in Hta. I'm going to cover 4 areas. So the first I'm going to cover is hygiene behavior. My original background is a public health microbiologist. Then I'm going to talk about some of the work I've done for the National Institute for Health and Care Excellence for their technology appraisal program, some of the nice process and methods work I've done, and finally a couple of pieces of the reviewing work I've done. I'm not going to go into a lot of detail, and as John said, you're not allowed to ask me any questions, but you can ask questions afterwards at the wine reception. So if you want to know more, just let me know. So I'm going to start with hygiene behavior first. Now, just a little bit of refresher for you about hygiene behavior. We're interested here in diseases that are spread by fecal-oral disease transmission, and the clue's in the name here. The person with the illness has the pathogens in their feces, and it spreads to another person who ingests those germs. Now, that can be either through contaminated water supplies, or it can be through poor sanitation. It can be directly by the hands. So hand washing is actually really important in this. This is actually a really big problem in a lot of countries in the world. Diarrhea is a major killer. It was 30 years ago when I did this research. It's still a major killer of children in developing countries. This is partially because children are often weakened from malnutrition, tuberculosis, HIV, and the diarrhea finishes them off. So I was particularly interested in the hand washing bit of this. Hand washing is actually really difficult if you don't have a tap near where you live, because people have to go collect water, bring it long distances. It's often far from the pit latrine which they use. So there's all sorts of challenges with with washing your hands that we take for granted. So there's a little refresher. So the first piece of work I'm going to tell you about took place in Zimbabwe. I lived in Zimbabwe in 1988 with my husband and baby daughter. I worked at the Blair Research Laboratory. And what I wanted to do was compare three methods of hand washing. I compared using the Makombi. This is a Makombi here. It's a galvanized metal container that you fill with water and you tip, and water comes out and you can wash your hands. And this is just outside of the pit latrine. That was the one method. The other method was soap and water, and the third method was traditional hand washing, which is just with water. What I was looking for was the presence of fecal indicator bacteria on the hands. So we tested those three methods in three different areas: a village, a commercial farm, and also a peri-urban area near the capital. And we were looking for fecal indicator bacteria on the hands. Now, I just want to tell you, this is a Blair ventilated improved pit latrine, a double pit latrine. This is very nice. This design has been copied around the world. It was developed here in Harare, Zimbabwe. It's quite unique in that there's I don't have a pointer on here, but the flow of air goes through the pit and up the chimney, so actually all the smells go out. So there's no flies. They're actually really pleasant to use. In fact, my father-in-law used to insist that these toilets were actually a lot nicer than toilets he'd encountered in continental Europe. So they're really quite nice to use. So, what did we find? We found that people who lived on the commercial farms, maybe you've seen in the press that people who live on commercial farms in Zimbabwe, there still are a few, but in those days there were quite a few. They're quite a deprived community, very marginalized. They had the highest level of bacteria on their hands. People who had infants in the family also had very high levels of fecal contamination on their hands. Of the three methods we looked at, soap was the most effective, but there were some problems with using soap to wash hands because people said that the soap left a smell on their hands. And if you eat with your hands, like a lot of people in Zimbabwe do, it affects the taste of the food, so it wasn't really very popular. The Makombi was the second most effective method. And people liked that because they said, oh, it was a nice reminder you could have it outside the pit latrine or at the edge of the compound if you were coming back from the bush. But there were some issues that maybe they would be too expensive for long-term use. And even alternatives like a plastic container or a naturally occurring gourd would have challenges as well. This was my very first paper in the Journal of Tropical Medicine and Hygiene in 1991. I was very pleased with that. The second bit of hygiene behavior work I just wanted to briefly mention is it was in Botswana. Again, I was looking at diarrhea, hygiene behavior, diarrhea in young children. I tested for fecal indicator bacteria on the hands and also in the environment. I also wanted to try and determine the prevalence of diarrhea and develop a hygiene index. So look at things like whether or not people had pit latrines, whether they had protected water supplies, whether there was animal feces in the compound. But most importantly, I wanted to know what mothers actually thought caused diarrhea and what they thought was dirty. And I used mixed methods research. I think this is before the days they even called it mixed methods research. I used focus groups and key informant interviews and all sorts of other qualitative methods to find out what mothers actually thought. I developed a chart here, you can just have a look at this, to ask mothers to monitor diarrhea. This was a little bit tricky because mothers are often, in this community, were semi-literate. We included cough and fever as well as diarrhea with illustrations and photographs and gave mothers pens and asked them to fill this form out on a daily basis to try and get an idea of how much diarrhea there actually was. And when health workers went to check afterwards, they thought this was actually really quite effective in gaining accurate information. So we were quite pleased with that. So what did we find in this study? We found that traditional beliefs were really important in hygiene behavior. So for example, mothers thought that things like infant feces and cow dung weren't dirty. So there's absolutely no reason to wash your hands after touching those. They also thought that diarrhea was caused by quite a few different things, one of which they called bad breast milk, or if a child was bewitched, or if a child had what they called pohwana, which is a traditional disease where children hadn't had the appropriate ritual purification rites after birth. So mothers often visited traditional healers for treatment and prevention of diarrhea. So our major finding from this study was that it was really important to include traditional healers in developing hygiene education messages associated with diarrheal diseases. Now, you may think hygiene behavior is all about in Africa, but it's not. This is a study I did in Leeds. I was commissioned to do a study to look at hygiene behavior in children in primary school. So this was in reception classes. And again, I was looking at fecal indicator bacteria on the hands and in the environment. Also, we wanted to test hygiene knowledge, so we developed a story, and this is a picture from the story, asking a few questions about hygiene to see what children knew. So this is Mr. Smiley. He's been out in the garden all morning. He's awfully dirty. He's going to come in now and have his lunch. He's got some lovely cakes, but what does he need to do before he has his lunch? Well, of course, hopefully you know the answer. He's supposed to wash his hands. And in this study, we found that the children who showed good hygiene behavior knowledge from the answers to those stories actually did have a lot less contamination on their hands. One thing that did surprise us, that classroom carpets were more contaminated than taps in the toilets or toilet seats or flush handles. Classroom carpets were the most contaminated area. Now, when we looked at that a little bit further, we realized that the toilets are cleaned very thoroughly every night, but people don't clean carpets in the classroom. Children sit there with their dirty shoes on, God knows what they've walked in. They rub around on there. They spend a lot of time with their stories and listening to the teacher and having discussions. So that was a target for improved hygiene in the classrooms. And also, boys had more contaminated hands than girls. So, now moving on to my work in Shire. I came to Shire in 1996. I was settled in Sheffield. I had 4 young children, and I lived here, and I needed a job that fit in with my family, so no more flitting around the world to Africa. So I was hired on a consultancy basis in Shire originally, and my first project, I think, was a systematic review on diabetic foot ulcers. So, and this is the days before fixed-term contracts, so I was hired on a project-by-project basis. So I had big gaps in between projects, and it was very, very part-time. But that fit in really well with my family. And during that time, I was able to develop my skills in systematic reviewing. I did a lot of training and did quite a few of them. So I thought that those 5 years I spent doing that were really quite useful. And I had 7 publications out of that as well, and realized that I really enjoyed systematic reviewing. So that was good. Now, I want to just stop before I go any further, because I think some of you may even be wondering, what is a systematic review? Now, and we get asked this all the time. Systematic reviewers, people say, don't you just cut and paste information on papers? Isn't that all you do? It's not quite that easy. This is a definition from the Centre for Reviews and Dissemination at the University of York. And in a systematic review, we basically try to identify, evaluate, and summarize findings from a whole bunch of relevant studies into one document. This is really important for people who are making decisions about healthcare. It's important for policymakers, it's important for clinicians, and it's also important for patients to find out if a treatment works. Now, we use standard, well-established methods to do systematic reviews, and we aim to make them replicable and transparent. So if somebody else did a review using our methods, they would hopefully come up with more or less the same answer. And the whole aim in a systematic review is to reduce bias. We start with a question, so you may say, does drug X work against condition Y to treat condition Y? And we use a focused question, so we may say, we're looking at, are we going to look at adults and children, or just adults? We focus according to these 4 criteria. Intervention, are we going to look at drug X in combination with another drug? Are we going to look at a certain dosage for drug X? What comparators are we going to look at? Usual care in the NHS? Are we going to look at a whole range of different treatments? With regard to outcomes, they could be clinical outcomes like reduction in blood pressure, or it could be something like a patient-reported outcome like patient acceptability or health-related quality of life. So we structure our question according to these criteria. We call this PICO. And we do this before we start. That's the key. Now, there's lots of categorizations about the steps in a systematic review that you'd find in the literature. I quite like this one. It's called SALSA. This is from Grant and Booth, and this is our very own Andrew Booth, actually, from SHAR. And these are the steps in a systematic review. We search and select the studies based on our question that I just showed you. We appraise the quality, and we have standard validated checklists to do that depending on the study type. We synthesize evidence. That could be numerically through something like meta-analysis, where you actually end up with a summary statistic or a number, or it could be a narrative synthesis where you summarize the key themes. And then we do an analysis where we look and say, all that evidence we found, does that actually answer all of our question, or are there still some parts missing? And those parts missing can often be the focus of primary research later on. So, systematic reviewing in a nutshell. So I was established as a systematic reviewer in SHAR, and my journey got a lot nicer in 2001 when I started to do work for the NICE technology appraisal process. Now, technologies are treatments. They're usually drugs, but they're not always drugs. They can be medical devices, and as you'll see in a minute, they can also be other things. And for those of you who haven't had the privilege of working on the NICE technology appraisal process, I'll just give you a little bit of a background here. This was set up to determine the clinical and cost effectiveness of treatments. We use standard health technology assessment methods, so we use a systematic review to say, does it work, does it have any adverse events, and a cost effectiveness model to say, how much is it going to cost the NHS compared to other treatments. In the original NICE technology appraisal process, we also did an assessment of the company's submissions. They presented their evidence about clinical and cost effectiveness, and we included that as well. Now, these are done by multidisciplinary teams, so I was part of a team as a reviewer, but they also include modelers, information specialists, project managers, statisticians, and clinicians. So it's a big team who do these. And all that evidence is used by the NICE appraisal committees to make decisions about whether or not to fund specific treatments for use in the NHS. Now, my very first project for NICE was not a drug. It was computerized cognitive behavior therapy. So this cognitive behavior therapy is an established psychological therapy for people with depression and anxiety. Well established, shown to be effective, but it's delivered through a therapist, and that can be quite difficult because it's expensive. There aren't enough therapists, so there's often long waiting lists. The idea was we could deliver this by a computer, so lots more people would have access to it. It would be less expensive, and it would free up therapists' time. This is in the days before there was a lot of internet use. So this was a standalone computer in a GP surgery or a library, and it was a pile of CDs that the patient had to work through. So what we found, there was very little evidence, but there was some evidence that CCBT was as effective as the CBT from a therapist. It was more effective than usual care from the GP, and there was a big reduction in therapist time, so that freed up therapists to treat patients with more severe conditions. This was my very first Hta monograph. I was very proud of that. And we were asked by NICE to update this in 2006 because there were lots more trials, and also there were it was being used for treating phobias and obsessive compulsive disorder as well. But even after 2 reviews, there were still lots of questions. What happens in the real world? These were all trials under ideal conditions. So what happens to patients who don't have that level of monitoring and input from the researchers? We also wondered what happened long term, because these trials were really short. They were only 3 months or so. And would relapse rates be the same as it would be from the therapist CBT, and also even usual care? There was also we had some information that GPs weren't very happy about CCBT because they had to do a lot of work to get everything set up, and if patients couldn't figure out how to use a computer. So there were some issues about that, and also there was always the concern from GPs about suicide risk. So there were some issues, and I think this is really a nice example of some of the challenges we face with health technology assessments and technology appraisal work. That sometimes you have to make a decision before you have really all the evidence. I also did a further review because I was really interested in finding out what patients actually thought about CCBT, because even if it seems to be effective, if no one wants to use it, what on earth is the point? So I looked at a lot of different outcomes to try and determine acceptability. The first one was take-up rates, and we found that lots of people were offered CBT, but only a very small percentage wanted to even try. Dropout rates were very high, but dropout rates are very high for all psychological therapies, so it was more or less about the same. And some of the studies we found did actually ask a questionnaire or a survey of patients to ask if they liked it, and generally people found it to be okay. So the real challenge was getting people to even have a go, but once they started it, they didn't find it bad at all. In 2003, I became the managing director of the Hta Technology Assessment Group, which is the group that does all these technology appraisals for NICE. We also do work for the National Institute for Health Research. It's a big program of work. We're one of 9 centres in the UK that do this work for NICE and IHR. Last year we had 39 people work on our project, so we've just started a new 5-year contract, and it's a big contract. It's over £6 million. And everything changed for us in SHARTAG in 2005. Some of you may remember the drug Herceptin. It was found to be very effective for treating a certain type of breast cancer. Lots about it in the media. The problem is that NICE process that I just told you about takes about 9 months. So there was a lot of pressure from Patricia Hewitt, who was the then Secretary for State for Health, to clip this along and get this drug through the system fast. So virtually overnight, due to huge political pressure, NICE developed a new process, which they called the single technology appraisal process, the STA process, which was to look at one drug for one condition. The original process that I described to you could look at several different drugs for the same condition. Now, this was also very different in that the manufacturer produced all the information about the clinical and cost effectiveness of the treatment. We had a new job, which was simply to critically appraise that manufacturer's submission. So it was very different. The whole idea was drugs would move through the system a lot quicker, closer to their licensing, so that everyone would be happy. But there were lots of reservations from the very start about whether or not this was going to be a very robust process. So now I'm just going to tell you a little bit about a couple of pieces of research related to that STA process for NICE. The first one was very, very soon after the STA process started. And this was we looked at the first 2 drugs, docetaxel and paclitaxel, for early breast cancer that went through the STA process. At the same time in SHAR, we were developing, a team developed a full report on the clinical and cost effectiveness of the same 2 drugs, so we could compare the 2 processes. And not surprisingly, perhaps, we found that in the STA process, manufacturers really weren't presenting all the relevant evidence. They were leaving things out of their submissions that were relevant. And also, their estimates of cost effectiveness were highly optimistic. Now, that's not changed. We still have those issues with STAs today. Further on, about 4 more years into the process, I did another piece of research where we wanted to see what was happening in the STA process. And we found that about half of the drugs, 48%, were cancer drugs, which was higher than expected. Over a third of the drugs were suspended or terminated, the STA, because they didn't get licensed when they thought they were going to be licensed. So that was a big waste of resources. It was an awful lot slower than had been originally anticipated. We think that was probably because manufacturers introducing extra information and also appeals and all sorts of other delays. But in the end, 76% of the drugs assessed through this STA process were eventually approved by NICE. We also went on to do a qualitative analysis of 30 of the reports written by the teams where they critically appraised the sponsor submissions. We wanted to see if there were some recurring issues, so there were definitely some recurring issues that kept coming up in the criticisms by the teams of the submissions. So we were able to develop some recommendations for manufacturers so that they could improve their reports and make it a more efficient process. That was the idea. And there was a real emphasis on clarity of reporting, particularly the reasons for selecting data that they included in their models, because it was often not clear at all. My journey with NICE continues. We have an ever-increasing number of STAs. We still continue with the original process, which is now called the multiple technology appraisal process. We do diagnostic projects for NICE, and we also do highly specialized technologies, which are drugs for rare diseases. And NICE is always changing what they do. They're just in the process of developing yet another process called the Accelerated Technology Appraisal process, which is going to be even faster for what they call Me Too drugs. So these are drugs very similar to drugs that are already in use in the NHS. And the idea is because these are so similar, they can go through even faster. So we're not sure what that's going to look like yet. They're also in the process of changing the way the appraisal committees operate so that they have to look at more topics per day. So it's an ever-evolving landscape. It's never a dull moment, really. You think you've figured it out and something changes. So I'm going to now tell you about a couple of pieces of research I've done on reviewing methods. The first one is about reviewing for models. Now I know we have some modelers in here, so I'm going to be careful about what I say. But this is a diagram to show the information that goes into a cost-effectiveness model. But first I just want to say, for those of you who don't know, cost-effectiveness model is an economic analysis where you compare two treatments, usually a new drug with what's currently being used in the NHS, and you compare the two treatments in terms of outcomes and cost. Now, when I first came to SHAR, I had no idea what modelers did. I had never even heard of modelers. When I was given a tour of SHAR the first week I was there, I saw that most people were in two-person offices. But there was a big room with lots of people in there. And I said to the person showing me around, who's in there? She said, those are the modelers. And I said, what do modelers do? And she said, they build models. And I thought, all that flashed through my head were my brothers who used to build plastic planes and ships and tanks. And I thought, surely that's not what they're doing there. And of course they weren't. They were building mathematical models by a computer. So now I know. Anyway, the model uses lots of information. This bit here, the clinical effectiveness review, is the systematic review. That's what the reviewer does. But there's lots of other information. This is very simplified that needs to go into a model. Now, this presents a lot of challenges for modelers, but it also presents a lot of challenges for us reviewers because we often get roped into helping. Often these needs for more information come very late in the process, so it can be very stressful. And the methods for doing this are not very well developed at all, so there's some real challenges. So how do you do it? Models are often perceived as a black box. You often see this as a criticism, that nobody's really sure how information goes in there, what happens in there in that model, and then how something comes out as the estimate. Modelers are often accused of cherry-picking data. They're accused of picking the best possible estimate. And there's all sorts of challenges here. The first challenge is how you select. You may have one or two choices of evidence. How do you decide which is the best one? And how do you report that so people understand why you made those choices? You may have reviewing challenges. If you've got a whole range of choices, how do you go through that reviewing process rapidly to come up with an answer? The standards for appraising these sorts of evidence, which are really not standard, are also not very well developed, so you sometimes have to develop your own. This is all really, really important, though, because the information you do put in a model does affect the answer. I want to tell you a little bit about some work I've done with Susie Paisley and Paul Tappenden on reviewing and selecting evidence for models. We did a series of focus groups with experts in modelling from around the UK, and we developed some recommendations on best practice. This was developed into a NICE technical support document as part of the NICE decision support unit, and acts as a sort of reference for people working in the field of HTA. We've also got a couple of papers out of this, and this is one from Value in Health. What did we find with regard to what's important with reviewing for model parameters? There's a real trade-off, balancing act between what's relevant and the quality of the evidence. So, for example, you may find loads and loads of studies that are high quality, but they're not relevant to what your question is. Maybe it's in a different patient population or a different country. You waste a lot of time. So the respondents felt that there was a real balancing act, and you had to take both into account equally. They also found that it's very important to be transparent about what methods you've chosen to select and review your evidence, and particularly where decisions have been very difficult and potentially controversial. And finally, there's a real place here for using more rapid review methods to speed things up. So the second piece of reviewing methods research is about rapid review methods. Now, systematic reviews take a long time. They take about 6 to 8 months, even longer if you've got a complex question. Sometimes decision makers need to make a decision before the review's finished. There can be lots of resource constraints. We're finding that funders are less and less likely to want to pay for a full systematic review. There's a whole range of options to speed up that process. There's loads in the literature. What isn't in the literature is how you choose your methods. So there's very little guidance on how you can speed things up. So we did some research where we looked at 3 distinct rapid reviews that we undertook here in SHAR for the National Institute for Health Research. So not for NICE, for NIHR. One of them was sexual health interventions for people with severe mental illness. One was treatments for premature ejaculation, and one was treatments for cannabis cessation. So very different topics, very different evidence bases. They all use rapid review methods. So we extracted information about what methods they chose and why they were chosen, and the strengths and limitations of those methods. And our findings were that it's really important to assess the current evidence base before you decide to do anything. There may already be a systematic review, so you can maybe update that, or there may not be so many studies, so you won't have such a big job after all. It may be important to consider how you present evidence, so you may decide to only present key outcome information only, or only certain types of information. What's really important is that the people who've commissioned your review actually understand what you're going to do and agree that that's okay, and understand any potential shortcomings from that. Again, clear reporting of methods is really important, particularly being clear about what your limitations are. Now I'm going to stop talking about research, and I'm going to talk about something else that's very dear to my heart, and that is work-life balance. I know about the challenges of raising a family and having a research career, so I just want to take a couple of minutes to talk about this. I've always worked part-time. I still do. And over the years, I've had some interesting comments from colleagues about working part-time. These are a lot rarer now, I'm pleased to say. I think attitudes towards part-timers are changing, and in fact 35% of staff in SHAR work part-time, so it's not just me anymore. This is my family when I started working in SHAR in 1996, my 4 daughters. This is my family. Now it's a lot bigger. I've got 2 son-in-laws, and I have 2 beautiful grandchildren. So it's a lot bigger. These are my grandchildren. They were not invited to this, particularly Jacob, because he would have been very disillusioned that we don't have Andy's Dinosaur Adventures featured, so he's at home. Does it get easier? People often ask me this, especially with small children, and the answer is yes. you'll be pleased to know. It does get different though. There's other challenges. I've got grandchildren to care for now. I have had a whole slew of elderly relatives to support. There's weddings to plan. And my husband's retired, there's lots of traveling to do. So the challenges get different. And I think for lots of us here, work-life balance is really important. Because I'm so interested in work-life balance, I've done a lot of work for Hta Swan. This is part of the Equality Challenge Unit, and it is focused on advancing the careers of women who work in higher education. This is because there's been a big disparity between career advancement for women compared to men in higher education in the past. Hta put in an application for an Hta Swan Award in 2012, and we got bronze. We put in another application in 2014, and we got silver, and we're just in the process of developing an application for renewal of our silver for next year, so it continues. And I do think things are getting better. I was just talking to John about this. This is our 19th inaugural lecture since 2008. And I'm the 9th woman. I don't have the data before 2008. I know there were some inaugural lectures. I think they were virtually all men. And there have been a lot of men since 2008 who have been eligible for inaugural lectures who haven't given them. But I think all the women, there's a couple after me who hopefully will be delivering theirs. As of today, and this does change remarkably frequently, there are 32 professors in Hta. 14 of them, 44% are women, compared to 63% of the research and academic staff who are women in Hta. 44% is actually really good. The national statistic is 22% of professors in the UK are women across disciplines, 22%. Some disciplines obviously have much fewer than others. In last year's staff survey, 85% of women said that Hta was a great place to work for women. But it's not just about women. I also do a lot of work for the Equality and Diversity Committee that I chair. We've done a lot of work on unconscious bias training throughout Hta, because we all have unconscious biases. Don't think you don't. We all do. And that's really important because it affects how we recruit staff, it affects how we promote staff, it affects how we give feedback, it affects how we select people to work on projects and to take on roles. So it's important that we all think about that. We've done a lot of work with the Hta core committees to make sure they consider equity and transparency when they select and rotate members and develop processes. And we've also done support for all staff in Hta for promotion. All staff in Hta now can access a CV advisor to get guidance and support on where they should be going with their career. And we also have a set of criteria for research and academic staff so people are clear of what they need to progress from one grade to the next grade. So the whole aim is that everybody who works in Hta, we celebrate the diversity, make it as equitable as possible, and make sure that everybody feels valued. So you'll be pleased to know I'm nearly done, because I'm keeping you, I know, from your wine. I want to say a few thank yous, though. I want to say thank you to Catherine. She's just snipped out, I think, but Catherine Rooney for organising everything so nicely. I want to thank the various people who listened to me ask for data and have so kindly provided it. I want to thank Simon Dixon and Alan Brennan for being really supportive line managers. I want to thank my husband Stephen for having to dig up a whole load of old photos for me. And my family, who are, all my daughters are here, Joanna, Katie, Abigail and Emma, my son-in-law Musanda and my husband Stephen. Only one son-in-law is missing because he's out of the country, Gareth. And I want to thank all of you for coming and listening to me. I'm very grateful. Thank you.
Okay, I'd just like to thank Eva on everybody's behalf for a fantastic lecture. It's the range of things that you've done. It's absolutely extraordinary. But I would particularly like to thank you on behalf of Hta for the work that you do for us about equality and diversity, if you like, in the broadest possible sense. I mean, it's great that most women in Shah think it's a great place to work. But the reason why they think it's a great place to work is because they have role models doing their work, and I think we should really thank you for that. As I said before, booze and biscuits, or